Hello and welcome to Alterations of Renal and Urinary Function. My name is David Woodruff. Let's take a look at some of the issues that we're going to have to deal with our patients who have renal and urinary problems. First of all, let's start out with some questions here. And just as a review of our anatomy and physiology of the kidney here, what is the functional unit of the kidney called? Well, if you answered B, the nephron, you are correct. The functional unit of the kidney is called the nephron. So that's where all the action's taking place. That's where the filtration's taking place. The glomerulus and all that is in the nephron. Okay, how about another question then? And then average, the kidneys receive approximately how much of our cardiac output? And if you answered C, 20 to 25% of our cardiac output is filtered through the kidneys. So, and this, obviously all of our cardiac output gets filtered through the kidneys at one time or another, but 20 to 25% of the cardiac output, which is coming out of the heart, is going directly to the kidney for filtration, and the other 75 to 80% is going to the rest of the body. So obviously the kidneys have a very high volume of blood flow that's going to them so that we can have adequate filtration and fluid balance maintained all the time. So we're going to have those things occurring all the time with our patient to maintain our equilibrium. Okay, how about another question here? The filtration of the plasma per unit of time is known as the glomerular filtration rate, GFR. GFR is directly related to the So if you said A, the perfusion pressure in the glomerular capillaries, you would be correct. GFR is directly related to perfusion pressure in the glomerular capillaries. Not the oncotic pressure or the vascular resistance, but our perfusion pressure. Let's take a look at our question here. Renal secretion of renin causes the direct activation of. Angiotensin 1. So our release of renin causes the direct activation of angiotensin 1, starting our angiotensin converting enzyme, our angiotensin, renin-angiotensin system here, that's modulated by the kidney. As a review, urine formation is going to occur in three different components here, or three different things that are happening to cause us to form urine. First of all, we have the filtration part. So glomerular filtration is the first step in our urine formation. So we have to have filtration through the kidney in order to start forming urine. If we're having problems with that kidney filter, we're not going to be able to form urine. And this is why patients who have chronic renal failure oftentimes develop anuria, which is a urine output of less than 100 milliliters per day. So less than 100 milliliters per day is called anuria. Oliguria is less than 400 milliliters per day. And again, this is the result of having filtration. Filtration is a direct factor of our glomerular filtration. So this is happening in our Bowman's capsule as a result of having adequate perfusion to the nephron. Next, we have reabsorption. This is occurring. See, what we're doing is we're filtering out all this stuff, and a lot of fluid follows the waste products that we're filtering out. Now, at the next stop along the way here, we need to, in the tubules, we need to reabsorb some of the water so that we're not dumping off as much water and losing too much water from the body. So reabsorption occurs. Also occurring in the tubules is going to be secretion. So we have reabsorption of fluid back into the bloodstream, and then we have secretion of those chemicals that are not needed by the body, and hydrogen and amino acids and things like that. Notice a couple very important ones in the secretion category here. Urea, which is a main component of one of the things that we're measuring on our patients with renal disease, which is the blood urea nitrogen, BUN. Also, creatinine. And these are two very important lab tests that we do on patients who have renal dysfunction to see whether or not the kidneys are able to excrete urea and whether or not the kidneys are able to excrete creatinine. Now, just as a little bit of a background here, urea is the byproduct of protein breakdown and protein metabolism. Creatinine is a byproduct of muscle breakdown. So these things are being produced all the time. We're constantly breaking down proteins, we're constantly breaking down muscle, and the kidneys are just able to secrete this stuff and get rid of it if you have normal healthy kidneys. However, if you do not have normal healthy kidneys, then what happens is the urea starts to build up in the blood, and that's called a blood urea nitrogen, BUN, and the creatinine starts to build up in the blood because the kidneys aren't excreting it, or secreting it rather, and then we end up having those lab values be elevated. And those are two primary lab values we use to tell us about renal failure. Notice also that hydrogen is secreted by the tubules here. So if we have renal failure, we could also expect that hydrogen would be kept in the body at levels that we shouldn't have. So in other words, we're unable to excrete that hydrogen, in other words, acid, and acid will start to build up in the body, and the patient will develop a metabolic acidosis. There are some hormones that are going to be produced by the kidneys as well. The first is renin, and renin is part of, or the beginning here, of the renin-angiotensin system, which helps us to be able to regulate our blood pressure. So angiotensin is going to cause the patient to elevate the blood pressure, and really the reason why the kidneys are producing this stuff is not to try to control the blood pressure out there in your arm. The kidneys really don't care about what the blood pressure is out there in your arm. The kidneys are trying to regulate their own blood pressure. However, this has a systemic effect and is going to have a systemic effect on blood pressure. The reason I mention that is because a lot of our hypertension that occurs in patients is the result of having too much renin released. And that is because the patient has some kind of underlying renal disorder. You're going to notice that patients who have renal failure often have very high blood pressures, and that's because renin is being secreted because the kidneys are saying, hey, we're not being perfused down here because there's damage to the kidney and the patient has renal failure. So the kidneys are releasing renin, and then renin is causing the blood pressure to rise in our patients. So you may see a high blood pressure in your patients with renal disease. A lot of our blood pressure problems come from renal dysfunction in one way or another. Erythropoietin, we talked about that before in our hematologic section, but erythropoietin is the primary chemical that's needed in the body to stimulate the production of red blood cells. Erythropoietin is going to be released from the kidney. So if we have renal problems, we could end up having a low erythropoietin level, which therefore would then result in having a low red blood cell count and anemia. So anemia could be the result of a patient having renal dysfunction. Next, we have our vitamin D3, which is involved in calcium reabsorption. So the very important piece there in order to be able to maintain our calcium levels. And what can happen is calcium levels start to become low. At the same time, the patient is having difficulty with filtering out phosphorus. Now remember, there's a balance between calcium and phosphorus. So if the calcium level is low and phosphorus is not being filtered out by the kidney, then what can happen is the phosphorus level can become very high. And this is the time we most often will see a high phosphorus level, is in patients who have renal disease. So we do need to make sure that we're maintaining an adequate calcium level and that we're controlling that phosphorus. In severe fasting, kidneys can also synthesize glucose. Not a normal function of the kidney, but the kidney can kick in when we need it in order to make glucose. Remember that the brain is totally dependent upon glucose. The brain cannot live without glucose, so we need to have glucose constantly in the body. And the kidneys can kick in and help out with that in a severe fasting. Let's take a look at another question. A waste product of protein metabolism is... Well, if you guessed D, urea, you are correct. A waste product of protein metabolism is urea. And normally urea is going to be excreted by the kidneys, but urea can start to build up in the bloodstream if we have renal disease, and that would be evidenced by having a high blood urea nitrogen, BUN, level. This is one of the lab values you'll be looking for in your patients when you go to clinical. What substance is an abnormal constituent of urine? So it shouldn't normally be there. Well, if you said glucose, you would be correct. An abnormal constituent of urine would be glucose. Glucose doesn't usually end up in the urine. The reason why glucose might end up in the urine would be that the glucose level is very high. The kidneys have a cutoff or a threshold for glucose. If the glucose level gets above 250, then glucose starts spilling out of the urine. Now, this is a protective mechanism. The kidneys are trying to protect the body from having very high blood glucose levels. Normally, we see urea in the urine. We see sodium chloride, in other words, salt is being excreted by the kidneys, and we see creatinine. Remember, urea is a byproduct of protein metabolism. Creatinine is a byproduct of muscle metabolism. Those things are normally excreted in the urine, so is sodium chloride. Glucose is not normally. It can be excreted in the urine, though, when the patient's blood glucose level is very high. Our renal function tests include what? Well, if you said both A and B, you would be correct. The urinalysis is part of our urine function test, and this tells us a little bit about what's going on with the kidney itself as to whether or not we have maybe blood that's starting to make its way into the urine, or we have white blood cells in there, or anything that's abnormal that's going to be in the urine itself. And we also look at the BUN and creatinine. Now, the serum BUN and creatinine are going to tell us about how well the kidneys are filtering these substances out. Remember, they're being made all the time, so there's a constant excretion of these things, and they will constantly be excreted by the kidney then. So let's talk a little bit about the BUN, and let's plug some things in here. The BUN measures the concentration of urea in the blood. Urea is formed by blank metabolism and is elevated in reduced glomerular filtration. So what kind of metabolism? Yeah, fill in the blank there. It's protein metabolism. Normal BUN is 10 to 20 milligrams per deciliter. So when you take your labs and you take a look at your labs on your patient in your clinical, you would expect the BUN to be somewhere in a range of 10 to 20. So we have a patient this morning, you take a look at their labs and you see that the BUN is 50. Okay, that's a reason for concern. The BUN is high. Now we would need to look a little bit more at what is causing that to occur. So let's take a look at our question at the bottom of the page then. BUN rises in states of blank and in states of blank and blank renal failure because passage of fluid through the tubules is slowed. Okay, well, maybe we start with the second part of our question there, in states of blank and blank renal failure. Okay, so that would be acute and chronic renal failure. Okay, that kind of makes sense, right? Since we're talking about different states of renal failure. But what else can cause the BUN to rise? The BUN rises in states of blank. And the correct answer there is dehydration. BUN rises in states of dehydration and in states of acute and chronic renal failure. Well, why would the BUN rise in a state of dehydration? My goodness, I mean, it's not like we're metabolizing more protein during dehydration. It's the same kind of thing that can happen as what we talked about with glucose. We can make that value higher by adding more BUN to it or by taking away the water. And in the case of dehydration, we take away the water. So you notice that BUN can be manipulated by a couple different things. It can be manipulated by protein metabolism. It can be manipulated by our fluid volume supply. So our more constant value than the BUN is the serum creatinine. Let's talk about that for a minute. Serum creatinine is a byproduct of blank metabolism. Okay, do you remember what we talked about here? It's a byproduct of muscle metabolism, and its levels of production are constant and proportional to the mass. Think about that for a moment. Constant and proportional to the mass. So let's say that you are taking care of somebody today who is a bodybuilder and they're, some huge 250-pound guy with all solid muscle here. All right, well, that person is going to produce more creatinine than somebody who doesn't have as much muscle mass. Does that mean that their serum creatinine level will be higher? Not necessarily. If we have normal renal function, the kidneys will dump it out. So normally it's not reabsorbed. The normal level is 0.7 to 1.2 milligrams per deciliter. One word of caution here, though, is just keep in mind that depending upon where you're doing clinical, they may use values that are slightly different than the values that we give you in class. Don't get thrown by that. Understand, different hospitals use different labs use slightly different procedures for testing. So let's say that you go into clinical and you say, oh, wait a minute, we learned 0.7 to 1.2, and here at this particular hospital, they are saying 0.8 to 1.3. Oh my gosh. Okay, well, it's just a difference in the equipment that they're using, slight difference in the variation as to what they consider normal. Well, we're not going to panic too much if somebody's creatinine level is 1.3 or 1.4 anyway. We are going to start to worry when the patient's creatinine level is 2. Okay, so you can see when we start getting pretty far outside of that normal range. Increasing levels represent decreasing blank rate. Okay, remember what we talked about just a little while ago, and the rate of glomerular filtration is going to control how much stuff gets filtered out. So increasing levels represent decreasing glomerular filtration rate. If doubled, renal function is cut in half. And we're talking about the creatinine. If the creatinine is doubled, the renal function is cut in half. If tripled, if that value is, say, 3.6, then our renal function, we're down to like 75% of that function being lost. We're talking about somebody here who now has renal failure. Another type of test that you can see, and you may see in some of your patients, is called the creatinine clearance. It is the amount of creatinine that is cleared by the kidney per minute. So we talk about this as being normal if it's 90 to 130 milliliters per minute as a function. So this is something that we're going to do. We're going to have to collect all the urine in that patient's body. We're going to have to collect all the urine that the patient's having for a 24-hour period and send that down to the lab. And then they measure the volume of urine over that 24 hours, and then they measure the amount of creatinine so they can figure out how much creatinine is being cleared per minute. This test is not done as often as it used to be because now we're looking more at our GFR rather than looking at the creatinine clearance. The third test that we use to tell us about renal function is our urinalysis. Urinalysis looks at the urine to find out what kind of stuff is normally there, what kind of stuff is abnormal, and if the abnormal things are there, why are they there? Is it damage occurring to the kidney? Do we have an infection? What's going on at the kidney that's causing those abnormal things to occur? Now, you may say, okay, well, with these other values, why do we really need to do the urinalysis? The urinalysis is quick. It's quick, it's easy, it can be done in a doctor's office. We don't have to send it out to a lab to be done. Very quick, easy type of analysis to do. They just simply take some urine, they take a little dipstick, they put the dipstick in it, and they can find out if some of these abnormal things are in there. So it is abnormal then to have blank, 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 or blank in the urinalysis. So let's take a few moments here to fill those little spots in. Okay, so it is abnormal to have red blood cells, white blood cells, bacteria, protein, glucose, or ketones in the urine. It is abnormal to have red blood cells. Normally, we shouldn't have red blood cells spilling out into the urine. That would indicate that something is happening with our vasculature. Maybe we have vascular permeability that's allowing red blood cells to fall out of the vasculature and get into the urine. It's unusual or abnormal to have white blood cells in the urine. The urine usually may have a few white blood cells in it, but any significant amount of white blood cells would indicate the patient's got an inflammation or infection occurring in the urinary tract. Next, bacteria. Isn't that interesting? It's abnormal to have bacteria in the urine. Okay, now urine in and of itself is rather sterile. Okay, it's not, we think of urine as being kind of dirty and gross and things like that, but urine is sterile. The problem with urine is it's a great place for bacteria to grow. So once it gets out of the body, bacteria will very rapidly grow in that urine. So for example, your patient may have a bag at the side of their bed that is collecting their urine, and that bag is a great place for bacteria to grow. So we have this nice warm substrate of the urine, will be a great place for bacteria. Protein is abnormal to have in our urine. We shouldn't be dumping protein, we shouldn't be dumping glucose, and we shouldn't be dumping ketones. So we shouldn't be making that many ketones. The ketones are getting dumped through the kidneys and into the urine. So let's talk about some urinary problems. The first set of problems we're going to talk about are urinary tract obstructions, and urinary tract obstructions can occur from a variety of different reasons. I'll tell you, the most commonly, the one we're going to see most often here is going to be that the patient has a stone in the urinary tract. So that would be the most common type of obstruction we would see. However, there's a lot of other obstructions that can occur. It can be an anatomical thing. So we could have just a narrowing of one of the ureters that was just anatomically, part of what happened with the patient, that's just how they grew. We can also have a number of other situations occur that could cause urinary tract obstruction, and we're going to take a look at those in here in just a few moments. But what happens when the patient has a urinary tract obstruction is that the kidney is going to start to swell. This is called hydronephrosis, where we're starting to have fluid inside the kidney, causing the kidney to swell and causing damage to the kidney. We'll have a decreased glomerular filtration rate because the pressure will be backwards on filtration. So rather than having the normal pressure of the blood supply pushing through the Bowman's capsule causing filtration, we're going to have pressure inside the Bowman's capsule from our urine backflowing, and that's putting pressure on the capsule and not allowing us to have a normal filtration. So the hydrostatic pressure of blood in the Bowman's capsule will not be able to overcome the pressure of urine that is in the Bowman's capsule, and filtration will not occur. At the bottom of the page, it talks about having some compensatory hypertrophy occurring in the kidney as a result of having obstruction. So the kidneys are trying to compensate by overgrowing, and so that they can push more urine out or filter more urine out of the kidney itself. So let's take a look at this picture here showing a number of different ways that we've got, or a number of different situations that have either caused or resulted in our urinary obstruction. So starting out on the left side at the top, we have our uretopelvic valve that's right outside of the kidney. Now, these valves are just like the valves in your GI system. They're designed to keep things moving forward, so we don't want urine backing up into the kidney. But that could be a problem if we have stenosis of that valve, then urine can't get out. We can also have a uretopelvic stricture, and then we see there is a narrowing of our ureter as it's coming down to the bladder. We can have a fibrous band going around the outside of that ureter, and basically a fibrous band is just simply scar tissue that is formed around the ureter, and it's kind of pinching off the ureter and blocking the ureter. We can also have stenosis of our ureter. One that is not shown there again is the stone, and stone is a very common cause for having a blockage of our urinary tract. We can have a narrowed ureteral orifice as it enters the bladder. That would be another possibility. We go down to the bottom there on the left-hand side, and urethral sphincter muscle. It could be like over hypertrophied or something like that that's causing too much pressure on the urethra and not allowing urine to be able to be excreted. We can have urethral stenosis. Okay, so the urethra itself can be stenotic, backing urine up into the bladder and then back into the kidneys. Over on the right hand side, going up from the bottom, we can have a posterior vesicourethral valve that is going to be hypertrophied, or it could be stenotic. We can have prostate hypertrophy. The prostate goes around the urethra, and if that prostate hypertrophies, it can cause constriction of the, can be putting pressure on the outside of the urethra, narrowing the urethral opening and causing a backup of fluid, a backup of urine to occur. We can have a posterior reflux of the valve as well. We can also have a dysplasia of the ureter, so that we're having an overgrowth of cells inside that urethra, making it thicker than it's supposed to be. We can have hydronephrosis, and you see, look at the two kidneys there, the one on the left and the one on the right. You notice the one on the right has this big bulging pelvis, as opposed to the one on the left has a much smaller pelvis. That's the hydronephrosis. So there's a lot of urine backing up in that kidney, causing that pelvis to really bulge outward, and we're seeing this big bulging pelvis. That's hydronephrosis. Obviously, there's so much backup of fluid in there, and there's so much pressure fluid in there, it's going to cause problems with filtration. Lastly, we have the polycystic kidney disease here, where there's all these little cysts that are forming on the kidney, and that's going to interfere with urinary function. Our upper urinary tract, we can have obstruction from stones. Okay, let's talk about those stones for a moment. So we typically call these kidney stones or renal stones, and you may hear people just talking about having had a kidney stone. Kidney stones are masses, and basically what it is it's like a rock. All right, so when you look at one of these things, they look like a rock. They look like gravel that's stuck in the kidney. And we'll see a picture of some stones here. But go down to the bottom here where the different classifications are. The vast majority of our stones are going to be calcium-based stones. They're calcium-based stones. Now, obviously, you can't avoid bringing in any calcium into the body because we need calcium as an electrolyte. We need calcium for the bone. So we do need to take some calcium in the body. However, that calcium is going to bind up with something called oxalate, and that combination there is going to make the stone precipitate, or going to make that calcium precipitate into a stone. And that's what causes the patient to have the stone formation. So we're going to manipulate oxalate rather than manipulating calcium in our patients. Also, a couple other types of stones that could occur. We can have uric acid stones. We talked about this with musculoskeletal, that the patient who has gout can have uric acid kidney stones. That accounts for a small percentage of our stones. And then struvite stones are another possibility. These occur in patients who have urinary tract infections. So let's take a look at our patient here with a kidney stone. We look and find out, does the patient have a history of gout? No gout. Okay, that's probably not uric acid. Does the patient have a urinary tract infection? No UTI, then it's probably not a struvite stone, and it's probably a calcium-based stone. Again, about 80 to 85% of our stones are going to be calcium-based anyway. Risk factors, gender. Women tend to have stones more often than men do. Fluid intake is going to be a big one here. So if you're not taking in enough fluid and you're not having frequent enough urination, and this is a big problem for nurses, okay, because we're out there running around all day long, and a lot of nurses don't take the time to drink, don't take the time to go to the bathroom, and what can happen is stones can form. We have to watch our diet, and this is very specific. Again, people who get calcium stones tend to get recurring calcium stones, and even though they watch their diet very carefully and everything else, they may not be able to avoid having that calcium stone in the future. Then back up toward the top of the page here, it says that this is a mass of crystals, protein, etc., that forms in the urinary tract and is going to block the urinary tract. So imagine you have a piece of gravel that is being formed in the kidney and it's flowing down through your urinary tract. Well, your urinary tract is just these tiny little tubes made up of tissue, and it's going to hurt to be running a piece of gravel down through that. So we could expect the patient to have pain in capital letters. Yeah. And what I've been told is that the pain of a kidney stone is similar to the pain of childbirth. Now, I have not experienced either, so I can't relate. However, from what I understand, it is very painful. Kidney stone formation occurs because we either have a supersaturation of one or more of these salts. In other words, we have a very high concentration of calcium that is getting to the kidney for some reason. Maybe the patient is starting to break down bone. Remember, one of those problems we had with musculoskeletal was a patient could have Paget's disease. That's a problem of bone metabolism, and the bone could be releasing too much calcium into the bloodstream, and that calcium starts to precipitate, causing a stone. That would be a supersaturation of one of these chemicals. Could also be a precipitation of a salt from a liquid to a solid. So changes in temperature, urine pH, very important factor here, and whether or not somebody's going to form a stone. And this is also true, not just of the stones we've talked about so far, but stones forming from some of our drugs that we give. We're going to talk about that a little bit later on. So then there's this crystallization or aggregation that occurs where the chemical is coming together, that the mineral is starting to bind together and causing the stone formation. Again, the presentation is going to be colic, in other words, pain. The pain may be intermittent and may be constant. Typically goes from the flank in the back and works its way down and forward as the stone is being passed. So how can we evaluate this patient and find out whether or not they have a stone? Well, we can look at their urine, and we can see if there's a stone. We may see stones in the urine. In addition, we may see a whole bunch of other stuff in the urine that isn't supposed to be there. As this stone is going down through the urinary tract, it's going to scrape the inside of the urinary tract. We're going to get red blood cells in our urine. We're going to get white blood cells in our urine. We could get little pieces of tissue in the urine. It's called casts. So all of these things can end up in the urine, and we can see that with the urinalysis. In addition, we can send that patient over to X-ray, and we can do what's called an IVP, an intravenous pyelogram, and what they do here is they inject the patient with dye. We then watch for the kidneys to excrete this dye, so the dye is then excreted out through the kidneys, and as it goes through the urinary tract, we're going to see the urinary tract light up on our X-ray. However, if the patient has a stone and the stone is blocking the urinary tract, we're going to see that white dye coming down and just simply stop at the point where we have the stone. Very dramatic, very easy to see the stone, but it does not pick up stones that are in the kidney pelvis or in the bladder. So in order to get those, we may have to do additional testing like a KUB X-ray. This is also called a flat plate abdomen X-ray. KUB stands for kidney, ureter, bladder X-ray. You're going to see maybe some of your older physicians write this KUB. Most of your younger physicians now are probably going to write this as a flat plate abdomen. Spiral abdominal CT. So we can do a CT scan of the abdomen and we can take a look at the abdomen. This is the gold standard here, is our CT scan. It's going to pick up those stones that are in the renal pelvis and in the bladder as well as in the urinary tracts. So here you can see this is a kidney, and they kind of cross-section here out a little bit, and we can see a lot of stuff going on here with this kidney. This kidney's got a lot of stones in it. And hopefully you can see by looking at this that these stones look just like gravel. That's what it is. It's gravel that is in this patient's kidney. And that it doesn't cause so much pain being right there. But when those stones start to break free and start to slide down through the urinary tract, that's when we get a lot of pain. We get the obstruction of the urinary tract, and we're getting the pain of that rock, that gravel, running through the urinary tract. So this just talks about some of the different signs and symptoms we're going to see in patients who have a renal calculi. This is another term for a renal stone. Increased incidence in males, nausea and vomiting, agonizing flank pain. And this is, people just really talk about how severe this pain is. Sharp, sudden, severe pain, hematuria, blood in the urine, dysuria, which means we're going to have painful urination, and then urinary frequency, so the patient's going to feel like they have to go all the time because they're not fully emptying the bladder. Diagnosis, again, we use our ultrasound. That's one possibility. IVP, we talked about that. We can do stone analysis, where we're taking the stone. If somebody happens to pass the stone, we're going to try and filter the urine so that we can look for stones. And if we find stones, we're going to send them down to the lab so we can look at them and find out what kind of stone that is. Retrograde pyelogram, this is a situation where we're going to put the dye kind of up from the bottom and look to see where the dye goes. We can also do a cystoscopy. I'd say by far the most common diagnostic test and way of treating stones nowadays is cystoscopy. Let's take the patient down to the OR, let's get them comfortable with anesthesia, and then they can take the scope up the urethra and they can get into the ureter. They can find that stone, they can visualize it, they can break it down, they can remove it from the body and open up that urinary tract again. Risk factors, infection, and again, that's going to cause a certain kind of stone. Urinary stasis and retention. So here's a big one. Urinary stasis and retention, immobility, dehydration. So those things are going to increase the possibility that we are going to have stones occur. So having those 6 to 8 glasses of water a day, like they always say, those things are going to be helpful in trying to prevent stone formation. Here's another one of our questions. A 25-year-old female is diagnosed with urinary tract obstruction. She is expected to have hydronephrosis and a decreased glomerular filtration rate caused by. So if you answered C, increased hydrostatic pressure in the Bowman's capsule, you are absolutely correct. The same female developed severe kidney obstruction leading to removal of the affected kidney. Which of the following would be expected to occur? Compensatory hypertrophy of the remaining kidney would be expected to occur because that remaining kidney is going to have to take over the function for that kidney that is no longer functioning well. Renal calculi may be composed of, select all that apply here. Okay, so the correct answers are calcium oxalate, uric acid, cholesterol, but not creatinine. Creatinine is a normal component of urine. As we talked about before with our picture, we can see that also a neurogenic bladder. So this is a situation where either the muscle becomes hyperreflexic so that it's not allowing the sphincter to open up, or the patient has the inability to be able to innervate the normal nerves that are necessary in order to release the urinary sphincter in order to allow a person to have normal micturition, which would result then in urine backing up and causing an obstruction. We can also have problems with bladder wall compliance, and this is if there's an obstruction of the lower urinary tract, that really increases the risk for the patient developing kidney stones here in the future. What this picture is illustrating is a number of different ways that we can end up having an infection occurring in the urinary tract. So we can have a blood-borne pathogen that gets, obviously, the kidneys are receiving 20 to 25% of our cardiac output with every beat of the heart. So lots of vasculature, lots of blood supply getting to the kidney. If there's a blood-borne organism, certainly it's going to be going to the kidney. Now, whether or not it takes up hold there in the kidney or not will depend upon what kind of organism it is. But certainly that's one way we can get an infection of the kidney, would be that the infection was already in the blood. That can then lead to the patient developing pyelonephritis, which is an infection of the kidney itself. Immobility can add to the chance that a patient's going to develop a urinary tract infection because we have a stasis of urine. Urine is kind of, in this picture here, it's kind of showing urine sitting in the renal pelvis there and not draining out. But the same thing happens in the bladder. Urine just kind of sits there in the bladder and doesn't drain out because the patient's immobile and we have parts of the body that are going to be dependent. Not a big deal while you're sleeping, okay? A lot of times while we're sleeping, we're moving around anyway. And as soon as you get up, then you're going to have your urinary tract in the proper position. It's really designed to be a vertical instrument rather than horizontal instrument. We can have other things occurring too. We can have our reflux occurring. We can have obstruction. Over on the left-hand side, you can see there that there's an obstruction causing a backup of urine into the kidney and causing the patient to develop infection that way. Having some kind of infection or inflammation on the outside of the body, or having E. coli, the patient's maybe not cleaning well after they use the bathroom, and we have E. coli from the intestine that gets into the urethra, works its way up into the bladder, and then back up into the urinary tract. So all of these are different mechanisms by which bacteria can get into the urinary tract. I think you're going to find most often what's happening is that we're getting bacteria from the colon that is getting into the urinary tract, the E. coli getting into the urinary tract, causing the UTI. So it's an inflammation usually caused by bacteria, so it's usually bacterial infection. And the most common pathogen is E. coli, and E. coli is a common or a normal flora that's found in the intestinal tract. We call it acute cystitis if the patient has a urinary tract infection that's acute and we're able to treat it with antibiotics, etc. Typically what happens is the person feels this overwhelming need to use the restroom. That's called frequency. They may have burning with urination. That's dysuria. This urgency, this feeling like, oh my gosh, I've got to go like right now, constantly, even though they're going like every 5 minutes. And usually what happens at that point is you're just kind of trickling out a little bit here and there. Lower abdominal and or suprapubic pain may also be accompanied with a fever, an elevated white blood cell count, and things like that. And interstitial cystitis is a little bit different than acute cystitis, and it's non-bacterial. So it's still infectious, but it's non-bacterial, very common in women in their 20s and 30s. This fullness, frequency, scant volume, chronic pelvic pain occurs with a interstitial cystitis. Pyelonephritis, in this situation here, now we have an infection that's occurring of the kidney, and that's most often going to be caused by urinary tract obstruction. So now we're starting to infect the nephron, and we have a urinary tract obstruction or a urinary tract infection that has backed up through the urinary tract. Now, most of the time, if you have a urinary tract infection, what will happen is because the natural flow is going to be downward, that you're going to be urinating out the bacteria rather than bacteria working their way up the urinary tract. However, if we have an obstruction or if the patient has something that might be decreasing their immune response, then that bacteria could work its way back up the urinary tract and get to the nephron and cause problems. Again, we're going to have flank pain, fever, chills. Bacteria in the urine and hematuria, blood in the urine as well. If it's chronic, we can see persistent and recurring episodes that lead to scarring. So we can have scarring of the nephron, and that can lead to the patient developing acute and/or chronic renal failure in the future. This is a picture here of a patient who's got pyelonephritis or had pyelonephritis. So you can see the kidneys are scarred. You can see all the damage that's occurred to them. They don't look like nice, normal, healthy-looking kidneys. And a common cause of pyelonephritis is so if you said B, invading ascending microorganisms such as E. coli, you were correct. Pyelonephritis is characterized by select all that apply. And if you said B, it's characterized by fever, chills, and flank pain, characterized by having the bacteria in the urine, blood in the urine, and having more common in young women than in young men. You were very correct. Glomerular disorders. So now we're talking about the effect now being directly on the glomerulus itself. So we're not talking about the outside of the kidney, we're talking about the glomerulus itself. And what happens in a glomerular disorder such as glomerulonephritis is the patient has an infection of the glomerulus itself. So this is going to cause a lot of problems with having normal function of our filtration mechanism. Remember, the glomerulus is our filtration mechanism. So we're going to have a reduced surface area, capillary blood flow, and hydrostatic pressure on the glomerulus, which will reduce our ability to be able to have normal filtration. We can have, as a symptom of a glomerular disorder, we can have hypertension. And this is one of the common presenting symptoms that a patient has when they have glomerulonephritis, is they present with hypertension. An increase in our BUN and creatinine and our urea, increase in our glomerular capillary permeability, plasma proteins in the urine, and we can see changes in our urine sediment as far as having proteins and fats and blood in the urine sediment and having a low albumin level in the body. So now what this all will end up developing is hypertension and edema. Glomerulonephritis is an inflammation of the glomerulus. It can be caused by an immunologic disorder. It can also be caused by some kind of systemic bacteria or virus. It can be a drug. It can be a toxin it causes, and it's causing inflammation to the glomerulus. Again, bad deal because the glomerulus is the filter, and if we're having inflammation of the filter, that's going to result in having decreased filtration and having hypertension and possibly having the patient develop also edema formation. Most common cause of end-stage renal failure is glomerulonephritis. So we have this chronic inflammation of the glomerulus, which then results in the patient developing chronic renal failure. This is a picture here, a couple pictures of a patient who's had glomerulonephritis, and we see just a lot of scarring occurring and redness and inflammation occurring to the kidney. So obviously these kidneys are not going to be functioning very well when the filter is this irritated and inflamed. Some of the symptoms we may see with a patient who's developing glomerulonephritis listed over on the right-hand side. So headache, elevated blood pressure. Now the headache comes from the elevated blood pressure. Facial and periorbital edema. So we have edema in the face, edema under the eyes, periorbital. Lethargy, low-grade fever, weight gain, so we have edema occurring, so we might see swelling in the ankles and swelling in the this other parts of the body here. We can see in the urine proteinuria, so protein in the urine, blood in the urine. We can have oliguria, so decreased urine output, or dysuria. We can have pain with urination. So all of those things can occur as a result. Usually what ends up happening is the patient presents with elevated blood pressure, so hypertension, and edema. Now, in a 75-year-old patient presenting with those symptoms, we might think it was of cardiac origin. However, if this was a younger patient presenting with those symptoms, we might be able to more closely identify the fact that this could be glomerulonephritis. So we have a 62-year-old female who presents to the health clinic complaining that she hasn't been urinating enough. She is diagnosed with chronic glomerulonephritis. The pathophysiology for decreased urine output in this patient is. And if you said D, thickening of the glomerular membrane and decreased renal blood flow, then you would be correct. Nephrotic syndrome is a situation where we have actually an increase in our glomerular permeability. So urine is, protein is leaking out. And we end up dumping excessive amounts of protein. Okay, so this is going to be a bad deal here because the patient's going to end up having a low albumin level as a result of dumping out all this protein through the glomerulus. Causative factor here is usually that we have some kind of glomerular injury that has occurred that is causing the protein to leak. We're going to see hypoalbuminemia, edema, hyperlipidemia, so the lipids are going to start to increase in the bloodstream and in the urine. Vitamin D deficiency, we're going to lose our immune proteins, which increases our infection risk because all proteins are being dumped through, not just albumin, but also our immune proteins are also being dumped through the kidneys, and we're going to end up having a low protein level. How we identify this in our patient is that we check the urine, and the urine is going to be positive, in this case very, very, very positive, for having proteins. Well, thank you for joining me for part 1 of alterations of renal and urinary function. Please move on to part 2 to continue.